Hi, I'm Jennifer Smith, and my case study is on rehab and long-term care, COPD, chronic obstructive pulmonary disease. So our patient is patient R. She's a 90-year-old female. She's a widow. She currently lives alone in assisted living. She's a former smoker of 40 plus years. She has 2 sons that are involved in her care on a day-to-day basis. As far as insurance, she has Medicare and a supplemental policy, and she has no cognitive impairments. So recently in the assisted living, Mrs. R, she suffered a fall in her apartment that resulted in a fracture, and this led to an exacerbation of her current diagnosis of COPD. She was transported to the hospital and then to the skilled nursing and rehab for rehabilitation with her hip. In order for the rehabilitation on her hip to be successful, it's important that the exacerbation of her COPD is treated. And her goal would be to return back home to the assisted living without any caregivers. So her past medical history, she has age-related osteoporosis, primary generalized osteoarthritis, COPD with acute exacerbation, acute and chronic respiratory failure, unspecified hypoxia or hypercapnia, hypothyroidism, unspecified vitamin deficiency, primary hypertension, hyperlipidemia, unspecified cerebral aneurysm non-ruptured, and of course the fracture of the unspecified part of the neck of the right femur closed fracture with routine healing. Her medication, she has quite a list of medications. So amlodipine 10 milligrams for hypertension, aspirin 325 for DVT prophylaxis, bisacodyl for constipation, calcium just as a supplement, vitamin B injection every 30 days, Dulcolax suppository for constipation, fluvastatin for the hyperlipidemia, and then for pain management, hydrocodone, acetaminophen 5-325, levothyroxine for hypothyroidism, melatonin for sleep, Miralax for constipation, a multivitamin, paracolase, Provenal aerosol solution, Spiriva, temazepam, and oxygen for her is 2 liters as needed for shortness of breath. So all of those medications she had prior to discharge to the hospital. So the pathophysiology of COPD exacerbation. So we all know it's a poorly reversible airflow obstruction and an abnormal inflammatory response in the lungs. So she has a hypersecretion of mucus, which this chronic bronchitis, tissue destruction, so emphysema, and disruption of the normal repair and defense mechanisms, causing small airway inflammation and fibrosis. So her EFL, or her expiratory flow limitation, is an issue for her. That's a consequence of the inflammation, so she has a harder time with gas exchange. Her airways are resistant, which is a problem, and that worsens the EFL. She does exhibit, as most patients do, a shallow, rapid breathing pattern, which makes it very hard to empty the lungs, further taxing her respiratory muscles. They're already burdened, they're overloaded, so there's a greater effort required to change volume in the lungs. So her baseline, her vital signs are stable. Everything looks fine there. She's 95% oxygen saturation on her 2 liters of oxygen. She's ambulating independently with a rolling walker for short distances in her apartment, and then she has an electric scooter for long distances and outings. She utilizes her oxygen about 85% of the day at the 2 liters. If you actually take a look at her hands, you can see clubbing is present. She has sluggish capillary refill, pale nail beds. In fact, overall, she's quite pale. She does have a moderate cough. Even without a stethoscope, you can hear audible wheezing. And then with the stethoscope, we can hear ronking. So, her baseline prior to the fall and the skilled nursing admission, what do we want to do as nurses? We want to make sure that her oxygen is applied properly. We want to educate the patient on deep breathing. We know that we become more anxious. She's already breathing shallow breaths, short breaths. So anxiety is only going to make that worse. She may begin to pant, further making it difficult to breathe. As always, we want to place the patient in an upright position, open up that airway, making sure that we can help her out with gas exchange. We want to encourage social activity and movement. We don't want her to isolate and just sit stagnant. So it's very important that she gets up and moves around throughout the day and that she has some social interaction. So it'd be important to obtain orders for physical therapy, especially as it relates to endurance. She's going to have a hard time because of her difficulty breathing, walking long distances. So anything we can do to help that would be important. And then we want to educate her on the use of nebulizer treatments and inhalers to make sure that she's getting her nebulizer treatments when she actually needs them, and proper use of the inhaler. Lots of times people don't use those properly, and they are not effective if they're not used properly. So very important that she understands how to do that. So critical thinking. Why is it important to encourage social activity and movement in a patient with COPD? So when we know things are hard, we are reluctant to do them. So dyspnea. Somebody with COPD, we know that they're going to have trouble breathing. And that makes them want to do less and less because that's easier. But the less they do, the less they're capable of doing. And then they're weak. Generalized deconditioning, and that something that can be prevented by being up and about. So again, why physical therapy would be so important. And what is the evidence-based practice recommendation oxygen saturation for patients with COPD? So as a general rule, we all kind of learn as nurses, we want somebody 91, 92% or above. Anything below that is critical. So for somebody with COPD, the evidence-based practice number is 90% or above. So stage 2. What does our patient look like when she admits to skilled nursing for her rehab? So we can see her blood pressure is a little higher, her heart rate's higher, her respiratory rate's higher. A little bit of a temperature versus what was going on before. And now she's at 92% on 2 liters of oxygen. So she's having rapid breathing. Upon a visual assessment, you can see that she's using her accessory muscles to breathe. She's got, again, pale nail beds and limited capillary refill, audible rales and bronchi, even without a stethoscope. She's got a heavy cough, thick secretion. She's anxious, and she is in pain. So she's reporting 10 out of 10 as far as pain goes in her leg. And that's very important because in order to help her to be more comfortable and ease her breathing, we want to get that pain under control. Nursing interventions when she goes into the skilled nursing. So we want to contact the physician for orders for a chest x-ray. She's got that thick cough with the mucus secretions and ABGs to see if she's acidotic or what's going on there. We want to give her medications for shortness of breath as they're ordered by the physician, again, to ease that breathing. Make sure that the oxygen is applied properly. We've all walked into a patient's room and the cannula is off to the side. It's, down, moved away from their nose. So make sure that it is in the nares properly. We want to place her in a high Fowler's position. Now she's in a place where she's not in a regular bed. She's in a hospital bed. So we want to get the head of that bed up. We want to educate her on the use of an incentive spirometer. Lots of times people like to blow into those. They can't figure out why it's not working. This will help move all of that mucus up out of her lungs, help her strengthen her lungs. So make sure that she's doing that properly and adequately throughout the day. And again, controlling that pain, very important. That will decrease her anxiety as well. So we want to get physician orders. So admission orders may look like this for someone on COPD. We want to give the oxygen 2 liters continuously, not PRN anymore. We want to monitor her oxygen saturation levels every 4 hours and as needed, depending on how she's doing. Prednisone, 40 milligrams for 14 days. We want to give her her albuterol nebulizer treatments 3 times a day as needed. Her inhaler, the Preventil inhaler, we want to give her 2 puffs every 4 hours. Advair Discus, Tramadol for the pain, Xanax for anxiety, again the incentive spirometer, and Mucinex, 600 milligrams. We want to do that so we can thin out those secretions and help her get all of that out of her lungs. Stage 2 critical thinking. So what is the evidence-based practice recommendation for steroid use in COPD exacerbation? So we know that we can't use steroids for long periods of time, and she already has some issues with her bones, so we don't want to use those for very long. According to this article, steroids improve several outcomes during an acute COPD exacerbation and a 10 to 14 day course of the steroids is appropriate. Now, is one treatment better than another? If we use the inhaler, if we use the nebulizer treatment, do we use them together? What's better, what's not? So evidence suggests similar benefit of meter dose inhalers when compared with nebulizer treatments for bronchodilator delivery. And finally, so she's gone through her rehab. She has worked with physical therapy, occupational therapy. We are ready to send her back to her apartment. It's very important at this point that we take a look and make sure that, she's breathing appropriately with the COPD, that it's under control, no longer exacerbated, and that we send her back to her home with a great foundation on which to continue. So we see that her vital signs are much more stable than they were before. Everything looks great. She's at 96% oxygen saturation on 2 liters. She can go 20 feet with her rolling walker without stopping. She is utilizing her oxygen 90% of the day, which is not unheard of. COPD is not something that's going to necessarily get better for her, so she may continue to utilize that oxygen more and more frequently. The clubbing is still there, but she does have improved capillary refill, pale on the nail bed still. Her coughing is resolved, so she's no longer having those thick secretions and that heavy cough, though we do still have audible wheezing. We would expect that in someone with COPD. Nursing interventions. So setting her up for success. We want to obtain orders for home health physical therapy, again with endurance, making sure that she isn't in a position where she's going to decondition and do so rapidly, so that she's up, about, moving, and strengthening, especially given the fall. We want to do everything we can to prevent her from future falls, so strength is very important. We want to explain all of the discharge medications and equipment. So incentive spirometry, making sure that she has a shower chair, making sure that she understands how to properly use that walker. We don't want her going down the hallway 3 feet behind the walker. It's only going to lead to an additional fall. And then because her family is so highly involved, we want to educate not only the patient, but the family on the signs and symptoms of respiratory infection. So because her lungs are compromised, she is at higher risk for an exacerbation and infection. And we want to make sure that she understands what to watch for. The thick mucus, different colors, making sure that she checks her temperature and she understands what to look for and when to call the physician. So critical thinking for stage 3. We're getting ready to discharge her. So why is it important to educate the patient on infection at discharge? So an estimated 70 to 80% of COPD exacerbations are triggered by viral or bacterial respiratory infections, and that's a very large number. So it's critical that she understands going home what to look for and that she's reaching out to her physician and following up as necessary, utilizing antibiotic therapy as needed. And name 2 things a patient can do to reduce COPD exacerbations. And the first one we all know is smoking cessation. So we don't want to further damage the lungs. We want to make sure that they stay as healthy as possible. And the second is vaccines, which actually ties into the first question. So flu shots, the pneumovax, making sure that she reduces her risk for future infection. Thank you so much.